Can everyone hear my voice properly? I would like you to reply on the chat whether you can hear my voice clearly before I start. Thank you. Okay. I will assume that everyone can hear me well. So I will get started then. Welcome to this webinar entitled The Elephant in the Room, Workforce Safety. My name is Sofia Macedo, and I'm a former critical care and cardiovascular nurse, and now I'm the manager for capacity building at the Saudi Patient Safety Center. Welcome to this webinar. What do you see in this picture? I was asked a few times why the name The Elephant in the Room for this session. As you can see in this picture, you have an elephant inside of what it looks like a meeting room. And it seems that no one is paying attention to that elephant. But it's actually impossible to say that no one can see it. So what it looks like is that no one is acknowledging it, correct? This is what I believe it happens within our healthcare systems when we're talking about workforce safety. So the elephant in the room, it's a major problem or a controversial issue, which is obviously present, but is avoided as a subject for discussion. In this following slide, I was eager to share with you a video that really shows why workforce safety is a major issue and why it is urgent that we do talk about it, whether we like it or not. But it's very, very important that we start addressing it before we move forward in addressing other issues within healthcare. I won't be able to streamline it right now because we are on a webinar platform. But once this presentation is ready and available to you through your email, please feel free to watch it, and hopefully you will understand why I felt this video was important. This video reflects a situation where a nurse, and this happened in Saudi, a Filipino nurse that was just doing his duty, and then you will see a relative, what it seems to be a relative, coming from a waiting area and seriously and severely stabs with a knife this nurse. The nurse obviously bleeds, and it's taken to care. When these situations happen, do you believe that a nurse that has just been injured by a relative or by a patient will be keen in ensuring the safety of his or her patients? At the end, we are all humans. And if we're not feeling well with ourselves, we won't be able to provide excellent care to others. At the completion of this webinar, I hope that you will be able to describe the current issues in workforce safety of our healthcare system, as well as the association between workforce safety and patient safety. Why is it important that we talk about this? We will also highlight recommendations for improving workforce safety, as well as review recommendations and practices implemented by organizations that have committed to ensure that workforce safety is a strategic key to ensure the safety of our patients. In this slide, you can see two pictures that reflect different approaches to patient safety in general. what I would like you to do is to take some time to analyze these two pictures and to think about what is common among those pictures, at the same time that you think about what is common in relation to patient safety. I'll just give you a few seconds. So the picture on your left side, called the Framework for Safe, Reliable, and Effective Care, it contains some aspects that we need to ensure to be sure that we provide safe care. And one of them, as you can see on the left up corner, it's something written called psychological safety. So basically what it says is that we need to create an environment where people feel comfortable and have opportunities to raise concerns or ask questions. The other picture on the right side of your slide, it explains the 6 domains for a culture of safety. And it's a guide in both a strategical and tactical manner to direct the efforts of organizations in creating and sustaining a culture of safety along the journey to zero harm. As you can see within this 6 domains, if you look onto your right upper side, there is a domain where you see trust, respect, and inclusion. So the reason I'm showing you this, it's to highlight that it doesn't really matter which framework, which approach you're going to apply to ensure patient safety within your hospital or organization, that any framework will always include the importance of workforce safety, whether it's physical, emotional, psychological. In 2013, the National Patient Safety Foundation's Lucien Lip Institute published a report titled Through the Eyes of the Workforce, Creating Joy, Meaning, and Safer Healthcare. As you can see, this report includes research on workforce safety, including physical and emotional safety, overview of challenges associated with workforce safety, recommendations for workforce safety, and case studies and exemplars of organizations who have demonstrated advancements and commitments to patient safety. So there are 2 concepts that it's heavily described in this report, and it's joy and meaning. And I'm just going to take a few minutes to clarify the difference between joy and meaning. So joy and meaning are specifically defined as joy being the feeling of success and satisfaction as a result of a meaningful action. It arises from within. It lasts in nature as compared to other concepts like happiness, which is a bit more fleeting. Meaning, on the other side, it's defined by the sense of purpose, okay, of an action. It's derived by a sense of significance, though it is not necessarily grandiose in nature. An example of something that is not meaningful on our daily work in a hospital, for example, maybe the routine hunting for devices or other equipment that we know consumes valuable time in the workday of many of our colleagues in healthcare. Well, I do remember when I was a nurse, for instance, we had to spend quite some time in searching for Dynamaps, for example. So those are actions that we don't feel them as meaningful. On the opposite side, an example of what may be meaningful, maybe when a team member is able to stop some sort of medication or an IV line because they're concerned that the situation may not be safe, either for the patient or for colleagues if it's a different situation. Another example of what may be meaningful might be the confidence and the comfort that our colleagues feel in their ability to report risks or events of harm, and their ability to be fully regarded as a member of the healthcare team whose ideas and suggestions for improvement and addressing their concerns are valued and respected. But all too often, and I guess we all can relate to this somehow, our colleagues are working in environments that were not free from cultural harm and disrespect. Such environments can so easily extinguish the sense of both joy and meaning of our workforce. We know that physical harm is a common occurrence in the healthcare industry. In fact, our healthcare workforce experiences injury rates that are 30% higher than other industries. Majority of nurses will indicate that unsafe working conditions can interfere with the delivery of quality care. And in major metropolitan areas, like Riyadh, for instance, a nurse or a physician has a 5 to 6 times higher chance of being assaulted than a taxi driver in the same area. What I'll show you now is 2 graphs, and I'll describe them for you so you understand a bit more what we're trying to say here. The graph on the left side of the screen represents data from the US Bureau of Labor Statistics. As you can see from the red line, I hope you can see it well, the causes of physical harm in US hospitals have consistently exceeded the average rates of harm across private industry in the US. The graph on the right side of your slide also shows that our healthcare industry, which is represented in red, it's one that is actually more dangerous or harmful than other industries that may normally be regarded as dangerous, like, for example, construction or manufacturing. Actually, there are more full-time equivalent days lost annually due to occupational illness and injury in healthcare than in other industries like mining, manufacturing, and construction, as I said before. So, considering that we are one of the industries that have more co-workers being harmed, how is that our healthcare workplace is getting harmed? So primarily is a result of overexertion of our bodies, as you can see in this graph, resulting in musculoskeletal injuries, which include but are not limited to our backs. Backs more related, probably nurses are the workforce group that will have more complaints on back injuries. And ironically, while we focus so much important work on preventing falls for our patients, this was quite an eye-opening even for myself. Slips, trips, and falls are a prevalent cause of harm to our workplace. Contact with objects, such as sharps, is another cause of workplace injury. And as many as you may be aware, violence is increasingly a common cause of harm. And this, it's reflected on the video that I wasn't able to show you earlier. This includes violence to our workforce can be patients, can be visitors, can be anyone who's able to enter the facilities, and with colleagues in our workforce. While the data I have just shared represents reports of injuries from the US, I have no doubt that there are similar patterns that occur in other countries, like in Saudi Arabia. Now that we've spoken about physical harm, I would like to take some time talking about another type of harm that it's perhaps more overlooked, which is what some of us categorize as psychological or emotional harm. Some of you may associate this type of harm with issues that relate to trust, respect, and fair and just treatment, and those that are all included in this type of harm. Fundamentally, our cultures are in many cases dysfunctional, and the root cause of this dysfunction is a lack of respect. It is near universally reported across all segments of our healthcare system. Additionally, frequent reports on the state of our workforce note that lack of support and appreciation, a focus on non-value added work like searching for Dynamaps, production pressures, scheduling demands and fatigue, poor design of work environments and workflows are ineffective communication, and conflict resolution also contribute to psychological harm. So, as recently was noted in a two-part series on respect, Dr. Lucian Leape and some of his colleagues make a clear but obvious statement. I know it sounds quite, obvious, but basically they say that when disrespectful behavior occurs, it must be addressed consistently and transparently. The degree of respect that everyone and anyone deserves in a high-functioning organization is a minimum requirement, and it is not a deemed status associated with who we are and what our job titles are. So let me just share with you some data in regards to how do people actually feel about psychological harm. So while we, at the same time, we encourage people to report errors, near misses, and events, we still see that some of our colleagues do not feel safe to report these incidents or errors. The fear of reporting concerns and errors and disruptive and unprofessional behaviors are all counterproductive to creating cultures of safety, cultures that are just, and cultures where learning from error is the norm. Okay? So basically, if we are afraid of reporting, we will never move forward to a culture that we feel it's fair. So let's look at some evidence, okay? So the evidence for addressing psychological harm, it's quite overwhelming, I would say. Across all professions in healthcare, we see daily reports of colleagues who consider leaving the practice or know of others who have left their medical, their nursing careers due to low morale. We see increased reports of severe emotional exhaustion. We see that many of our colleagues are thinking about leaving their jobs. Perhaps you can think about someone that had told you recently, I'm tired of this job, I can't do this anymore, I'm going to leave sometime soon. Including those that are new to their professions and increasing vacancy rates. And we also see that a few CEOs and other healthcare leaders have taken up the challenge to transform their organizations. In some cases, they report that their return on investment is indeed not there. So this means that there's still the belief that whether you invest or not on promoting a healthier environment, that the return on investment isn't there. You don't really see why you should do it. So let's take some time to look into this inventory. So this Maslach burnout inventory was developed by a lady called Christina Maslach and al., and is a validated survey that has been extensively studied. The inventory will address 3 general scales including emotional exhaustion, dispersonalization, and personal accomplishment. Recognized for more than a decade as the leading measure of burnout, this inventory will incorporate the extensive research that has been conducted in the more than 25 years since its initial publication. The surveys address emotional exhaustion or measures of feelings of being emotionally overextended and exhausted by someone's work. It also measures dispersonalization, measured as an unfeeling and unpersonal response toward recipients of one's service, care, treatment, or instruction, and it also reflects personal accomplishment, which measures feelings of competence and successful achievement in one's work. So, what are the costs of inaction? The costs of inaction appear to be increasingly prevalent as we see study after study that notes concepts such as burnout, which we just described, stress, and turnover. Absenteeism may be a key marker of these issues. We see the correlation, and those of you that have been, if you've been managers before or had nurses or directors in any sort of leadership position, you've seen the correlation between poor survey of safety culture scores and instances of patients, families, and the workforce. So it's basically all interrelated. And we have reports of patients and families that continue to be caught in the fray again at a time when they need us the most. So basically, when patients do need us the most, it's when we are so tired that we will probably not provide the care that our patients deserve. Also associated with harm to our workforce, when the care that we are expected to provide is actually not provided. So this is what we call missed nursing care or miscare. This type of care is care that is deemed essential or necessary nursing care that doesn't get done. And even in high-performing hospitals, including magnet-designated organizations, there is a large percent of nurses who report missing at least one and oftentimes several nursing activities during the last shift. Some of the elements of care that have been reported across studies have included ambulation, interdisciplinary care conference attendance, oral care, timely medication administration, and turning. Those of us that understand clinical indicators, we can see immediately what will be the effects of missing care, for instance, on turning a patient. What is the impact on pressure injuries prevalence, for example? While there is less data available on other disciplines, an example of missed care for physicians may include missed communications in critical care test results, for example. And why is this concept of missed care so important? And how does it relate to the joy and meaning of work and workforce safety and obviously patient safety? Studies reveal that a correlation between teamwork and missed nursing care. And in fact, when teamwork is stronger, less missed care is reported. However, when healthcare professionals are unable to provide the care that patients and families need and that they are expected to provide, there can be diminishment of joy and meaning of work. As you may understand, if we don't feel that we've delivered to the maximum extent of expectations and what is ethically it should be, our feeling of joy and meaning of work, it's going to be diminished. Now, what is the price of workforce harm? What is the price tag, as I like to call it, of a workforce that it's not protected and it doesn't feel safe? It's increasingly clear that if we're not aligning our focus on the costs of workforce harm, which is both, as we saw, physical and psychological, there are undisputed consequences for healthcare organizations. When we look at the costs of running our business, it's increasingly vital that we understand, I'm sorry, that healthcare organizations are being built for a very costly lack of attention on many of the related physical and psychological issues that have been brought up so far in this session that I'm presenting to you. So, what is the cost when you're there, but you're not? And I'm gonna clarify to you what I mean with when you're there, but you're not. So the costs of workforce and wellness and harm are typically not areas of focus, as we saw, or priority for the leaders of institutions. However, some do focus on physical harm statistics. These statistics are typically derived from our colleagues in occupational health. Usually this is the department that will collect and provide us some indicators on how well or not well the workforce is doing. A more in-depth understanding of the true cost of unhealthy or harmed workforce is critical for healthcare leaders to understand. The cost of health and productivity of our workforce has profound financial implications, which include the costs of providing medical and pharmaceutical care as needed. Okay, so in this study from the occupational health literature provides evidence that the health-related productivity costs of an unhealthy workforce are quite substantial. Much of our workforce is dealing with chronic conditions such as you can see on the graph, depression, obesity, musculoskeletal injury, and other diseases that are reflected on the graph. I'm not going to go through all of them for the sake of time, but again, when you have the slides, you can see it more in detail. Even if we are able to assess the costs of claims data for the medical and pharmaceutical needs of such chronic conditions, a workforce that has such conditions will likely have and factor costs of unwellness, such as absenteeism and presenteeism. I know those are maybe two new words for you. I'll hope I'll be able to clarify them properly so you can understand what I mean. Our occupational health colleagues, they also note that the costs for absenteeism and presenteeism for many conditions that affect the general workforce and the healthcare workforce are far higher than medical and pharmaceutical costs. This study, the one we can see reflected on the slide, notes in the yellow portions of the bar graphs that you can see, reported rates of presenteeism as associated with certain conditions that include physical and mental health issues. So let's take some time to look at what is this presenteeism that I keep talking about. And I'm sure you will be able to relate to this. So basically is you're at work, but you're out of it. So basically presenteeism is not just about showing up to work and, as we say, goofing off. Presenteeism is the loss of productivity due to the real health problems. It's taking our illnesses to work. Presenteeism is effectively when the warm bodies of our colleagues are actually physically working alongside us or in their offices, but have lost productivity and are physically or emotionally unable to give 100% of focus and effort on their work when they're actually at their place of work. So basically, you're at work, but you're not really working. Presenteeism is highly prevalent in organizations that have employees who are depressed and suffering from anxiety. Presenteeism occurs in all workforces, even those that are healthy, but are a special cause for concern in unhealthy workforces and in workplaces that do not place a high priority on workforce safety. So as you can see here on the graph, the costs with presenteeism, which means losses in productivity due to health conditions, are higher, far higher, 63%, than direct medical costs. Like if you have a flu and you have to take medication and just do some medical interventions, which is 24%. So there was a recent survey of board members and CEOs that was conducted by the National Patient Safety Foundation and assessed the self-reported practices, knowledge and understanding of chief executives and board members of patient and workforce safety. A small percentage, or 31%, as you can see down in the bottom, in bold, of the respondents, in this case were the board members, affirmed that a workforce safety dashboard was reviewed at every board meeting, while only 8% of the CEOs said that they also do the same. This kind of finding, as you may understand, suggests that key leaders and governance bodies are not as informed or focused on workforce safety, which is regarded as preconditional for safety. We can only act on an unhealthy workforce if we know how it looks like. And we will only know how it looks like when we measure it and when we assess it, when we analyze it, and that will put us forward to take an action. In the same survey, it was asked the board members and the CEOs to rate their knowledge and understanding on a number of patient and workforce safety topics. The percentage noted here reflect the percentage of respondents who rated their knowledge and understanding as high. So as you can see in the survey, self-reported knowledge and understanding of workforce safety issues was less likely to be reported as high as nearly all other topic areas. You will note on the slide that while a greater percent reported a high knowledge of understanding of employee satisfaction, there was a marked decline in surveys of patient safety, the physical and emotional workforce safety challenges and reports, turnover, and workmen's compensation rates. In all cases, smaller percentage of board members rated their knowledge and their understanding as high as compared to their chief executive officers. So let's try to tie all this data that I just presented to you about physical and psychological harm to the workforce into an inherent logic cascade, okay, that brings us back to the topic of joy and meaning. We know that effective, safe care requires effective care delivery organizations. We also know that effective organizations care for their employees by continuously fulfilling some basic preconditions, including cultural freedom from harm and disrespect. These preconditions enable employees to habitually pursue excellence and engage in continuous learning. Employees who derive joy and meaning from their work and their organizations experience better outcomes in this logical cascade that I'm just showing, and focus on supporting the safety of the workforce. So let's look into some guiding principles that Lucian Leap report provides to us. So these guiding principles are meant for leaders and for all of us that are in healthcare. This report states guiding principles for addressing issues of workforce safety and states that the purposeful creation and maintenance of these preconditions It's the primary role of leadership and governance. It also states that the absence of violation of these preconditions obscures meaning and drains motivation while imposing significant costs on the organization, its employees, its patients, and the economy, and the costs associated with patient harm and workforce harm. The other guiding principle that's emphasized in this report, as you can see, it's that safety and respect of the workforce are critical for patient safety and for the workforce to focus on becoming habitually excellent. There are 7 organizational imperatives that are recommended in the report that we saw about joy and meaning of work that I have been referring throughout the webinar. The first is to develop and embody shared core values of mutual respect and civility, transparency and truth-telling, and placing physical and emotional safety of workforce and patients at the highest level and the highest strategic imperative of leaders. It recommends adopting the explicit aim to eliminate harm to patients and the workforce, and also to commit to creating high reliability seeking organizations and demonstrating the discipline to achieve highly reliable performance in not only reducing harm for patients and families, but to the workforce. There are additional recommendations for this report and include to create a learning and improving system and adopting evidence-based management skills for reliability, establishing data capture, database, and performance metrics for accountability and improvement of workforce safety that are transparent to all, recognize and celebrate the work and the accomplishments of the workforce regularly and with high visibility. So it's when we celebrate accomplishments, we need to ensure that it's visible to everyone. And to support industry-wide research to design and conduct studies that will explore issues and conditions in healthcare that are harming our workforce and patients. On this note, I would like just to highlight the reason why perhaps when we develop sessions or presentations, and perhaps when you've done it yourself, it's quite hard to find data that it's Saudi-based. So this is one of the imperatives that we need to also consider in Saudi. It's to start creating our own data, our own reports. So perhaps in a few years' time, instead of me presenting data from the US, for instance, I will be able to present data within Saudi Arabia. However, we know that the data from other countries, it's quite generalistic to other countries also. The challenges of our healthcare workforce, they're quite across the globe, but it is important that we do know how our picture looks like in our country. So how do we do this alignment of the safeties? And when I talk about the alignment of safeties, I'm talking about the workforce safety and the patient safety. How do we ensure the balance, this perfect alignment? It is clear that workforce safety has to be aligned with patient safety, and that prioritizing and taking sustainable measures to improve the safety of our workforce has to be a vital imperative for leaders. Our collective efforts to address and accelerate patient safety will be hindered and continuously challenged in organizations where our workforce is not healthy, it's not engaged, and it doesn't feel safe. Workforce safety must be aligned with and integrated into our overall patient safety strategies. So how this alignment will look like when we actually make it happen in an institution. Let me share with you an example of an institution that had this alignment happened. So this is a hospital with 363 beds and nearly 2,500 employees. And it's part of an 11 hospital network owned and operated by a company called Ascension Health in Central Texas, okay? The graphs on the next, on this page, on this slide, show what happened at this hospital when they began adopting high reliable organization principles and applying them simultaneously to patient and worker safety. The incidence of serious safety events affecting both patients and workers declined. As you can see on the graph on the left of your slide, the red one, it's the recordable injuries or illnesses per 100 full-time employees, okay? And on the right side, it's the number of serious safety events. So the employee injury and illness rate went from 6.5 in 2009 to 4.9 in 2011, which was around 28% below the industry average, which in that year was 6.8. Over the same period of time, the number of serious patient safety events per year also fell, as you can see. Because of this achievement and this alignment, in 2012, following a comprehensive external review, this hospital committed to become a high reliability organization. The team went beyond just to worry about equipment and procedures to actually create a prevention-based culture of safety. In the process, this hospital has seen that associating safety and patient safety are closely linked. In fact, associate safety and patient safety depend upon and reinforce each other. So how do we ensure that the safety of our healthcare workforce is present? So perhaps some of you are quite familiar with this report. Personally, I feel that it's never enough to bring it up to the stage. So in 2015, the National Patient Safety Foundation convened a global panel of safety experts to examine the state of patient safety 15 years after the publication of the report "To Err is Human." This seminal report identified that preventable medical errors was a growing concern and was likely contributing to substantial preventable death each year. While many experts on this panel felt that progress has indeed been made in safety since that time, which was in 2001, there were others who felt the progress has been very, very slow. The resulting report of the National Patient Safety Foundation's Expert Roundtable, titled "Free from Harm: Accelerating Patient Safety Improvement 15 Years After to the Other Report, the "To Err is Human," concludes that while progress has been made in patient safety, there are still unacceptable rates of harm that affect patient families and our workforce. This report calls for a total systems approach to safety. So what is this total systems approach needed, and why does it support patient safety at the same time as it supports workforce safety? So the experts on the panel examined why other industries were also able to make the shift from high incidence of preventable harm, yet healthcare has remained mirrored in slow progress, and in some cases, perhaps no progress at all. They agreed that a substantial mind shift from the piecemeal and often reactive approaches to addressing safety should shift to a total systems approach to safety, and that this should become a focus of all leaders and employees in the healthcare industry. So what does a total systems approach to safety look like? So, and why is that important for this webinar on joy and meaning of work? The first recommendation for a total systems approach to safety requires constant prioritization of a safety culture by the team, which is vital for patient and workforce safety. It requires a focus on safety across the entire continuum of care and on workers across the continuum of care. It addresses both mortality and morbidity, and not just key statistics like survival or major surgical complications that we are always used to hear about. It includes prioritization of the well-being and safety of the workforce and the commitment to zero harm, not only for patients, but to our healthcare colleagues. And it avoids adding disjointed initiatives to a stressed delivery system and workforce that it's unable to keep pace with or safely provide care in our current environment. So let's look at some recommendations of the report that can help some of you that might be thinking on implementing a better workforce environment. So while all the recommendations of the report relate to our workforce, a few are indisputably linked to what we're talking about in this webinar. The first recommendation, ensuring that leaders establish and sustain a culture of safety, calls for culture as the essential underpinning for any safety initiative. While culture has remained relatively dormant in the majority of healthcare organizations who have spent much time, energy, and money focusing on quality initiatives, it is proven time and time again that in the absence of a safety culture, the progress that we make will be inhibited and unable to be sustained. So basically, it doesn't really matter the quality initiatives we put together to improve patient safety if we don't have initiatives to improve workforce safety. It will just not be sustainable. Supporting the healthcare workforce was identified as a key recommendation from the expert panel that we've been talking about, who noted that workforce safety, morale, and wellness are absolutely necessary to providing safe care. This report indicated that every employee in the healthcare workforce needs this full commitment from leadership to fulfill their highest potential as healthcare professionals. This recommendation includes focus on physical and emotional harm. This is a very important point I would like to stress. It's not just about physical harm, it's also about emotional and psychological harm. It's not as obvious as physical harm, but it can have longer and lifelong effects other than the physical harm. So the experts define specific tactics and the rationale that relate to supporting the healthcare workforce. This includes, as you can see in this slide, the adoption of modern quality improvement tools and methods and training of all professionals, okay, including leaders in safety culture and implementation throughout their career trajectory. The rationale of this tactic is that providing the knowledge and skills to improve safety may improve job satisfaction, engagement, resilience, and therefore patient safety. The second tactic is to expand or develop resources that support the workforce including initiatives to improving working conditions and establish an environment of respect, programs to support staff and improve resilience, fatigue management systems, and communication and resolution programs for patients and families when harm occurs. The rationale for this tactic is that workforce safety is a precondition to patient safety. However, physical and psychological harm and burnout are highly prevalent in healthcare and are preventing us from making advances in patient safety. The third tactic is to involve the workforce in identifying domains for measurement and creating workforce safety and wellness dashboards to be reviewed by leadership and boards. The rationale for this tactic is that standardized measures of physical and psychological safety are not available for senior leaders to review, and this practice is uncommon, as noted earlier in this presentation, when I showed you the two tables where we had the survey made to the CEOs and to the board members, and where we saw that they weren't very familiar or they wouldn't even look at their dashboards at all. So what are some of the initiatives that are advancing and improving workforce safety? So as you can see on the slide, more than anything, it is a leadership priority to set nothing less than a goal of zero harm to patients, families, and to the workforce. So what do leaders really need to do or must do to meet this zero harm goal to patients, families, and workforce? So other obligations of leaders are to ensure that there is an agenda item at all board meetings on patient and workforce safety. I don't know how many of you actually sit at executive meetings, and if you do, I'm not sure how many actually go through a patient or workforce safety. Perhaps patient safety, it's more common. I'm not sure about workforce safety. So if you're not aware, try to find out whether you have a dashboard that measures or reflects the measurements of workforce safety in your organization. So to mandate full accountability for reporting and eliminating workforce safety issues across the organizations, requiring the use of workforce safety dashboards, as I told you before, understanding the rates and types of harm within their workforce, encouraging real-time, internal and publicly transparent reports of workforce safety, include sessions about workforce safety in daily patient huddles and briefings. And if you're not aware what huddles are, I will explain later in this webinar. And engaging occupational health, human resources, and organizational development in workforce safety as equal team members in addressing and improving the safety of our workforce. Other areas of focus and emphasis for leaders, including developing appropriate committees that proactively address known and suspected sources of hazards to our workforce, ensuring that meaningful programs and incentives are in place for worker engagement in programs that promote health, wellness, and provide peer support and resources as needed, including for harm events and violence, adding workforce safety stories at board and leadership meetings, town halls, and in relevant value analysis, and purchasing decisions, and investing in technologies and resources to ensure safety of the workplace. So what I'm going to show you on the next two slides is a picture of several organizations that have participated in the LEAP program. This program refers to the leading edge advancing patient safety topic on culture of safety. integrating worker and patient safety. Okay, so participants in this program include several hospitals engagement networks that adopted explicit aims to reduce harm to their workforce. This is an example of a dashboard that displays percentage change in injury rates from baseline by participating members. This second slide shows the reduction in employee turnover rates in one hospital engagement network member who saw turnover rates fall from above the national average to the national average rate over a period of simply a few months as a result of focusing on workforce safety. I believe we are all well aware of the high turnover rates that we have in our country. There are multiple factors, and one of them is definitely harm in the workplace and a workforce that doesn't feel safe and protected. I'm not sure if you have access to your data of your institutions on why do people leave, but there will be an interesting exercise if you haven't done it yet. So earlier on, I mentioned about a strategy called a safety huddle, or some of us call it patient safety rounds for patients and the workforce. So what is this? So many organizations are now implementing daily or shift huddles where not only patient safety issues and concerns are addressed, but workforce safety concerns are also identified and discussed. In addition, many leadership and management teams are beginning their days with organization-wide safety calls that focus on patient and workforce safety. This strategy is also being adopted not just within clinical areas, it's also adopted in more, let's say, office-based areas where people gather in the morning just to make sure that everyone is aware of what's happening, everyone is aware of who's the busiest person on that day, on that shift, on that ward, so people can support each other during that workday. Specific examples of preventing physical harm to the workforce include organizations that have invested in safe patient handling devices to reduce musculoskeletal injuries, safety technologies to reduce sharp sticks, ensuring ample access to hand hygiene stations, personal protective equipment, reducing the risk of slips, trips, and falls, programs for dealing with violent patients, including alert systems and Kevlar protection. So these are all examples of strategies that institutions implement to prevent physical harm. So fatigue, and I'm pretty sure that this is something that most of us can relate to, results in the impaired function resulting from physical labor or mental exertion. There is clear and overwhelming evidence that associates fatigue and extended work hours with greater harm to patients and to our workforce across all professions in healthcare. I can give you one example where a nurse who works for more than 12.5 hours has 2 to 3 times greater likelihood of making a medication error. Yet longer work shifts, such as 12-hour shifts for nursing, provide many benefits that also provide joy and meaning to our colleagues. So this is something quite interesting, because even though evidence shows that if we work more than 12 hours, we have higher rates of committing errors. nurses tend to be happier when they have 12-hour shifts because of, you know, the way they work. They get to have more days off. So the balance here for the risks and the benefits of those longer shifts, it's to have leaders that focus on workforce time on the job and to ensure that staff do not work over the 12-hour periods that they've been assigned to, and that the number of the 12-hour shifts is reasonably reduced, that circadian rhythms are included in considerations for scheduling between days and nights, and that breaks are clearly provided for adequate nutrition and rest. And also, there is a situation where, I mean, we do understand that because of shortage of staff, sometimes we have to do it, but we should always aim for mandatory overtime to be eliminated. I know it is quite a common practice in some hospitals across the country, but we should try as leaders to minimize it to the maximum. Otherwise, we may end up with people overworking and therefore more chances for patients to be harmed due to exhaustion of our healthcare providers. Organizations and leaders must also be trained on the harmful effects of fatigue on patients and workforce safety, and implement fatigue management systems throughout their organizations. So there are additional examples of focusing on the workforce safety relate to the legendary work of the former chairman and CEO of Alcoa, Paul O'Neill. He put forward a challenge to his organization and any organization really across the world that aspires excellence in care. This challenge is very, very, very simple. And basically, it's asking us if can each person in your workforce answer affirmatively to these 3 key questions every day, and if not, joy, meaning, and patient safety cannot be realized. These 3 questions include, as you can see on the slide, am I treated with dignity and respect by everyone, every day, by everyone I encounter without regard to race, ethnicity, nationality, gender, religious belief, title, pay grade, or number of degrees or credentials? Do I have the things I need in terms of education, training, tools, financial support, and encouragement so I can make a contribution to this organization that gives meaning to my work? And again, the importance of finding meaning on what we do. And last, am I recognized and thanked for what I do, I would say, every day. So with attribution to the Kaiser Permanente, I would like to note the Kaiser People Pulse Workforce Safety Index. So this is an index that which embeds measures of Mr. O'Neill's 3 key questions, the ones we've just seen, in regards to respect, resources, and recognition. In addition to Kaiser's Workplace Safety Index, includes a question about necessary steps that are taken in my department or work unit to ensure employee safety. Kaiser has shown that the results of these questions can be used to predict vulnerable departments and identify areas to improve in the work environment in order to potentially prevent injuries and harm. So I would somehow dare for you to take those questions out into your work areas and try to see what do people answer. And again, you may be actually very, very surprised with the results. So the Workforce Safety Index program has revealed that workforce injury rates are significantly lower in departments with higher scoring results. Higher workforce safety index scores are also associated with fewer bloodstream infections and pressure injuries. Additionally, departments that report greater comfort voicing their opinions, speaking up about errors and mistakes, and environments that encourage better ways for getting work done show lower workforce injury rates. So as you can see, it's all interconnected. And we saw on one of the earlier slides that if you do have a safe workforce, you have safe patients. And when I say safe patients, I refer to examples I've just given. For example, bloodstream infections, pressure injuries, and so forth. So other approaches to improving workforce safety are deceptively simple, but include focusing on positive psychology and resilience. It's a human concept that we are often hardwired to remember the negative experiences that we have. Somehow we tend to remember always the bad things. But by focusing on good things, we can indeed create lower instances of burnout and depression, improve happiness, improve work-life balance, and improve sleep quality even. Dr. Brian Sexton from the Duke Center for Patient Safety has a 3 Good Things program. It's very interesting and very simple, which is a 2-week survey that encourages every participant to note 3 good things that have happened on any given day over a 2-week period. Results from participants in the survey have shown that when they're able to focus on good things that happen every day, they are statistically significant improvements noted in the areas that we have just described, with lower burnout and depression, higher happiness, improved work-life balance, and again, sleep quality. Other simple approaches to addressing workforce safety include simply bringing up workforce safety, which is not commonly discussed in our current healthcare system. So basically bringing up the elephant to life. As individuals, as team members, you can ask yourself the following questions. Do you know your rates of injury and the associated cost of injury to your workforce? Do you know and are you collaborating with your occupational health, environmental health, and human resource leaders? And have you worked on collaborative programs to address workforce safety priorities within your organization? Is workforce safety even addressed at all in your strategic plan? Other questions may include, does your organization have a workforce safety dashboard? What's on this dashboard? Who actually sees this dashboard? Are your workforce injuries publicly posted? Is your data accessible in real time, such as organizations like Cincinnati Children's make available? What happens to your colleagues after a safety event occurs? Do we know when, for example, someone has reported an adverse event? Do you know what happens to those colleagues? Do you have an employee support program in place or a peer support program? Do you have an employee fatigue management system or an health and productivity management program in place? So those are questions that you can start asking. I can assure you that some people won't really appreciate those questions to be asked because, again, it's the big elephant in the room that people tend to not wanting to address, but it is the foundation of us understanding how safe or not safe is our workplace. Because as we discussed throughout this webinar, until we get this piece right, all initiatives we may put forward for patient safety, they won't be sustainable. So as we approach the end, in summary, we've taken the time to review the current state of safety of healthcare workforce. We have also addressed causes and consequences of physical and emotional harm to our workforce. We've also discussed solutions to improve the physical and emotional safety of workforce. And it is my hope that you have an improved understanding of the criticality of workforce safety and the importance of the alignment between workforce safety and with patient safety. And that the message you take away from this webinar is to incorporate ideas into your workplace and into the care of yourself and your colleagues. Workplace safety is heavily linked to patient safety, as I keep mentioning. Unless caregivers are given the protection, the respect, and the support they need, they are more likely to make errors, to fail, to follow safe practices, and not work well in teams. So as I finish my webinar, in a trial of really wrapping up this, and the best analogy I can think of to summarize what is the importance of workforce safety is those of us that drive, that have a car, we do know that unless we care for the engine of the car and we have enough fuel to feed that engine, that unless we do that, the car won't take us anywhere. And it doesn't matter how pretty the car is. It doesn't matter how beautiful leather seats I have or how high-tech my car is that can talk and do all sort of things technologically. If I don't have the engine and the fuel for that car well treated, that beautiful car won't take me anywhere. And this is how I see workforce and patient safety. Workforce, our nurses, our physicians, our pharmacists, our technicians, everyone within the healthcare industry is the engine and the fuel for the best care for patients. So if we don't treat this piece first and we ensure that we maintain a healthy workforce, everything we will try to do to ensure the safety of our patients, it's not going to be sustainable and it will eventually fail and it will be very, very costly to any organization. So I do hope you enjoyed this webinar. It is an elephant in the room that most people don't like to really address. They may acknowledge that it's there sometimes, but we need to do more about it. This webinar and presentation will be sent to you once it is over, and please do feel free to go and see the video that I had right in the beginning, so you understand what I meant when I said if we don't feel safe as healthcare professionals, we won't feel with a good mind to protect our patients. Okay, so I wish you well. And do you have any questions before we finish the webinar? I'm happy to take any questions now. If you do have questions, feel free to type them on the chat. Well, I guess that there are no questions. If you do have questions after we finish the webinar, please feel free to get in touch with us at the Saudi Patient Safety Center. We're more than happy to support you with any initiative, with any tools that you may feel your organization or yourself could benefit from. So have a good evening, and I hope to see you all very soon. Thank you.